Heel spurs, those little bony points they see on x-rays. These heel spurs don't belong in physiotherapy. Physios don't treat the bones. Sure, we say we treat stuff like wrist fractures, but what we mean is we treat the results of the wrist fracture. It's the orthodox who treat the fracture. They put on the cast, they do the surgery. Physio sees them after that. So we don't treat heel spurs, but we do treat the pain and difficulty walking that our patients have. This is the difference between a doctor's medical diagnosis and a physio's functional diagnosis. So why do I say forget heel spurs, you have plantar fasciitis? It's because most heel pain, most plantar aspect heel pain is plantar fasciitis. It could be something else, and that's what we need to talk about. So my subtitle should be The Differential Diagnosis of Plantar Aspect Heel Pain for Physiotherapists, but that didn't work for marketing purposes. This differential diagnosis is either traumatic or non-traumatic. I know that sometimes the history is muddled. With trauma, anything is possible. Bones can get fractured or bruised. Sometimes the doctors argue about what they see on x-rays. As the physios, you have to go by the patient's signs and symptoms. Treat the patient, not the x-rays. That is to say, acknowledge the patient complaints there's something going on and don't make things worse, but we do need to improve our patient's function. That's why we're here. Soft tissues get sprains and strains. I've seen way more Achilles tendon ruptures than plantar fascia ruptures. I've seen loads of heel pad injuries. Heel pad injuries may or may not be traumatic, but they give local pain and tenderness on the bottom of the heel, especially with weight bearing. Most non-traumatic plantar aspect heel pain is plantar fasciitis. The key features of plantar fasciitis are the plantar arch foot pain and tenderness from the ball of the foot to the heel, usually medial aspect of the heel where the plantar fascia inserts, and pain upon weight bearing after rest, like first thing in the morning, those first few steps after getting up. Plantar fasciitis is usually non-traumatic. As an aside, I did have a traumatic plantar fasciitis patient. A karate guy had kicked with the bottom of his foot. That impact on the bottom was irritating enough to cause plantar fasciitis. The treatment was the same as non-traumatic. The two big sports where you see different parts of the foot used for impact are martial arts, like karate, and soccer. The other two things to consider in your differential diagnosis here are the skin and the nerves. Skin issues usually go outside of the typical physio scope of treatment, but they are a part of life, so look at the foot. Any signs of anything should prompt you to slide on a pair of gloves. Normal healthy skin isn't contagious, so I wouldn't wear gloves with every patient. And yes, of course, we wash our hands between patients, right? But when the skin looks irregular, use gloves. Make note of warts, nodules, psoriasis versus eczema. Athlete's foot can look like redness between the toes. There are tons more yucky pictures on Google. If you're interested, search for skin problems. My advice to physios is to avoid diagnosing any skin problems or lumps. Let the physicians take the lead on that. As physios, we need to avoid irritating anything and emphasize pain-free exercise use with our patients. So like I said, irregular skin, wear gloves. Don't touch those nasty toes and then scratch your face. It's called cross-contamination, and it's not something you want. The other issue with differential diagnosis here is nerve involvement. That's numbness and tingling. Diabetics usually get this in both feet, but one foot can be worse. Morton's famous neuroma affects the ball of the foot up into the toes, but you can get neuromas anywhere. Pinching a nerve can also give paresthesias like tarsal tunnel syndrome, but it may be higher up. At the level of the knee, it's usually peroneal more than popliteal, or from the hip or back. It's usually back more than piriformis, so do your history and exam to track that down. My point here is to answer the question about foot pain and heel spurs. Bones have all kinds of lumps and knobs. Remember anatomy class? Not only the bones, but what attaches to all those bumps and ridges. That's Wolff's law. Bones change due to applied stress, which comes from German anatomist and surgeon Julius Wolff and has nothing to do with werewolves. I get that question a lot. I see a lot of post-traumatic immobilization, fractures or surgeries, and plantar fasciitis. What feet do you see a lot? What questions do you get about foot pain? Let me know in the comments below. My 2 books are now available at Amazon. What they don't teach you about documentation in physiotherapy school, a short how-to manual for successful daily note templates, and From Injury to Recovery Through Exercise, simple functional exercise progressions for physiotherapists to restore lifting, standing, walking. Thank you for your support. Watch this other video here or subscribe to stay tuned for more videos. Thank you.